Thank you very much for the very kind invitation to speak. As was mentioned, I'm Fionnuala Mcauliffe and I'm from National Maternity Hospital in Dublin. I'm honoured to work with many of my Indian colleagues through my work in FIGO, and in that role I have developed a number of toolkits for nutrition and pregnancy, pre-pregnancy checklist and pregnancy passport. So the title of my talk is What to Do When Cancer is Diagnosed. So that's a picture of the hospital there. As you can see, the sun is always shining in Dublin, just like in Mumbai. And that's a picture of me there with my team. We are a large university perinatal research centre with 8,000 births. And we do complex obstetrics in our unit. Okay, so I start with the case. A 32-year-old woman, it's her first pregnancy, she's 28 weeks, and breast cancer is diagnosed on biopsy. So you receive a phone call from the surgeon. So these are the sort of phone calls I receive, and they have two questions. One is they're worried about surgery and fetal well-being. Is it appropriate in pregnancy? She's 28 weeks. And also they would like to do a gadolinium imaging for sentinel node mapping, which would be normal when you're staging cancer. So this is our patient here. So hands up, what is appropriate? So should we do left lateral tilt with intraoperative CTG and readiness to do a cesarean section in the event of an abnormal CTG? That's option one. Hands up for that one. Or the second option is we do left lateral tilt with fetal heart auscultation or Doppler check prior to surgery or within a few hours. So who would propose we do intraoperative CTG monitoring? This lady is 28 weeks and she's going to have surgery. So the correct answer is we wouldn't do intraoperative CTG because of course there may be changes in the CTG and we certainly wouldn't want to deliver a baby at 28 weeks. And of course that will interrupt the surgery that's planned for her. What about the gadolinium mapping and staging? Should we go ahead and do it as usual, or are we concerned about it? So anyone want to offer an opinion? So in general, we tend to avoid gadolinium mapping and CT because of the concern for radiation to the fetus. So she's now 32 weeks, she's had her surgery, and she's due chemotherapy as per usual non-pregnant protocol. So what do? Do we defer chemotherapy until after the birth because we're concerned about giving chemo to the mother and baby? Or should we continue with chemo and deliver after 38 weeks? So anyone want to suggest? Would we deliver 32 weeks and get on with treatment, or would we treat her? So there's increasing evidence now that we should get on with chemotherapy and aim for a term birth. So I know that might be a little opposite to what you're thinking, but of course if you deliver the baby preterm, this is exposing the baby to unnecessary prematurity, and many chemotherapeutic agents are safe in the second and third trimester. So the current thinking would be that we would treat the mother and go for a term delivery. So you might say, well look, I don't like the sound of chemotherapy in pregnancy. What are the risks? And the studies are limited, but we have reasonable long-term follow-up to show no impact with certain chemotherapeutic agents on infant long-term health. How big a problem is cancer in pregnancy? Well, this is some data from Britain and Ireland inquiries into maternal mortality. And you can see there that malignancy is an important cause of death in pregnancy and the 6 weeks postpartum. And as you may know, in UK and Ireland, we also follow deaths for 1 year postpartum, and you can see that malignancy appears quite significantly as well. So it is something I'm sure many of you have seen here in the audience, and certainly something we're seeing on a regular basis. What sort of malignancies were there from the women who died? Well, you can see that breast cancer is very common, cervical cancer, and the various blood cancers. And looking at the stage, so this is quite interesting. So the darker the colour, the earlier the stage. And you can see there that cervical cancer is presenting early. But something like gastrointestinal cancer, which there is an increase worldwide in gastrointestinal cancer, you can see they're presenting quite late in pregnancy. And I've certainly seen 3 cases recently of advanced GI cancer presenting in pregnancy. So it's the second leading cause of death in the reproductive years, and it complicates about 1 in 1,000 pregnancies. And of course, where there is an increasing age of childbearing, and my hospital, half of our women are over the age of 35. So we're seeing more cases for that reason. And I'm sure many of you are seeing cases amongst your own older pregnant population. So these are the incidence of pregnancy-associated cancers, cervical and breast, followed by melanoma and lymphoma. So the question will be, does pregnancy worsen the prognosis, or does pregnancy prevent treatment? And I guess I would encourage you to ask this question of your oncology colleagues, that when they phone up and ask you for advice, I would ask you to ask them, if the woman was not pregnant, what investigations would you do and what management would be offered? And if they're suggesting differing investigations or management, you need to say, will this impact on her long-term survival? And you need to have a good reason to offer her anything other than what would be standard, because we don't want, this is a woman with a young family, we want to maintain her survival for as long as possible. So what investigations would you normally do, and what management would you normally offer? You need to get a multidisciplinary team discussion. So in our setting, we have access to oncology, and then there's midwifery, maternal medicine, fetal medicine, and her surgeon, and perhaps pharmacy. We look at the maternal prognosis, the impact of the fetus. We need to consider, does she want to terminate the pregnancy and start treatment then? And we need to think about delivery, gestation, and mode of delivery. Now, interestingly, for breast cancer, the diagnosis tends to be delayed in pregnancy because, of course, the woman and her healthcare providers may think that the lump is normal in pregnancy. But interestingly, the other reason why breast cancer often appears to be advanced is because younger women are more likely to have estrogen and progesterone negative cancers, and younger people generally have more aggressive cancers. So overall, the data would suggest that there is no impact. So if she gets her cancer during pregnancy, there's no evidence that it will be more advanced and her survival will differ than if she wasn't pregnant. There's an additional thing to consider for melanoma, leukemia and lymphoma, that it may spread to the placenta and rarely to the fetus. It's pretty rare, but for that reason, we should do placental examination and follow the infant up clinically. And of course, surgery can be performed as usual. There's no need to delay surgery, and just make sure you have an obstetric anaesthetist on board to help you with the anaesthetic agents and of course that left lateral tilt. In terms of radiotherapy, this is contraindicated in pregnancy unless it's required for organ function preservation. So for example, if she has a symptomatic brain tumour or a spinal cord compression. And then chemotherapy, as I've mentioned, we have good evidence of safety in the second and third trimester. In terms of radiation, so fetal exposure, if it's greater than 0.1 to 0.2 grays, well then that is harmful during organogenesis and is associated with congenital anomaly and IQ reduction. If it's needed for organ preservation in the mother, we could consider in second and third trimester, but generally we avoid radiotherapy in pregnancy. And this is just a table to outline the various effects of different doses of radiation on fetal development. In terms of imaging modality, and this comes up from time to time, I mean, many of the my radiology colleagues will say, oh, we can't do that investigation because she's pregnant. But of course, most investigations, you can see there, the risk to the fetus is very low. And if staging is required to determine the appropriate management, I would get on and do staging as per usual. So in terms of first trimester, if she presents an early pregnancy, there is a concern about teratogenicity with chemotherapy. So a reasonable option might be termination of pregnancy in that setting, if you don't want to delay giving chemo, but of course we can give it in second or third trimester. We try to avoid a situation where we're delaying chemotherapy for fetal viability, which may then go against her prognosis long term. So we in FIGO, together with the Committee on Cancer, are currently developing guidelines for the care of women with cancer in pregnancy. And this is just a sneak preview of some of the tables that we are working on. And you can see here in this table, we've pulled out those chemotherapeutic agents for which there's reasonable safety data. You can see there that citabarin is reasonable safety data. We've got reasonable safety data for doxorubicin and cyclophosphamide. So there are a number of agents that can be used. A common one would be the vinca alkaloids, taxanes, and platinum agents. So we need to think about a multidisciplinary team discussion. If you're going to deliver preterm or you're going to do surgery, you need to think about antenatal steroids. And then just to remember, in terms of chemo, we need to give 2 to 3 weeks of washout, because if the baby is born with chemotherapy on board, they're poorly able to metabolize it. It puts the baby at risk of neutropenia. So we would wait 2 to 3 weeks after the last chemotherapeutic infusion before we deliver. And of course, for the mother, if she delivers with chemo on board, she's potentially more likely to get perinatal sepsis. And then in terms of starting chemo, 1 to 2 weeks after vaginal delivery and 2 to 4 weeks after cesarean section to allow tissue healing. So you can see in these cases, there's an advantage for vaginal birth because it means that she can start her chemo. And therefore, there shouldn't really be much of a gap between, if you add 3 weeks before birth and 2 weeks after, she's really only ending up with a few weeks of gap in her chemotherapeutic regime. In the UK, we've gathered data on breast cancer and pregnancy, and I just share some of that with you. Looking at the characteristics of the women newly diagnosed with breast cancer, you can see there that BMI is a factor, but what I found very interesting was that 50% of the women had a pre-existing medical or mental health problem, excluding obesity. So women with medical disorders were overrepresented in this group of women presenting with breast cancer and pregnancy. They looked at staging and noted that about half of the women didn't have the appropriate staging because of concern about impact on the fetus. So again, if we don't properly stage the woman, we're not in a position to offer her optimal treatment. So we need to think carefully about staging her correctly. And then in terms of chemo and timing of birth, so in this case, there was 12 women who were diagnosed in the 3rd trimester, and they could have received at least 2 cycles of chemo, but only 1 of these women did. So certainly in the UK and Ireland, we are encouraging that there is not a delay in the starting chemotherapy. We can deliver, give chemo in 2nd and 3rd trimester. And rather than, and I can understand the urge to deliver preterm and then treat postnatally, but we need to say there are treatments available that we can give and go for a term delivery. So in terms of the work that we're doing in FIGO on the management of women with cancer and pregnancy, and we're actually planning 3 papers, 1 for cancer and pregnancy, 1 for women who've had cancer and are planning a pregnancy, and a 3rd one with the fertility committee on fertility preservation in women who've got a cancer diagnosis. So this is a summary. Obviously, we need good, accurate pregnancy data, dating, to confirm viability. We need to make sure there's no fetal anomaly there if we're encouraging the woman to carry on. And of course, when we take our samples from her surgery, we need to inform the pathologist that she's pregnant, because that can change a little bit the appearance of the tissue at histology. Keep an eye on fetal growth and plan any surgeries for early 2nd trimester. Remember the lateral tilt, and after the surgery, we can monitor the fetal heart. And then think about the chemotherapy. As I've said, we can give it in 2nd and 3rd trimesters. In terms of delivery, try to avoid prematurity. I mean, we need to think we have a woman here who has a cancer diagnosis. The last thing she needs is a baby in the neonatal unit because we've delivered too early. So we need to work hard to give her a nice term baby that she and her family can take home without requiring a lot of neonatal care, and she can focus on her cancer treatment. And there's no contraindication to a cesarean section except in the case of genital tract tumours. And then postpartum, we need to think about VTE prophylaxis because they're particularly at risk of VTE. We need to monitor the fetus, send the placenta for histology. In the rare case that it may have spread to the placenta, we might need to follow up the infant. And I think if the mother did receive chemo, it's reasonable to follow up the infant for any adverse effects. And then just a very nice infographic from our team in FIGO in terms of, you can see there that it's not just us or the oncologists, that there's a lot of input for the care of women who have a new diagnosis of cancer in pregnancy. And then, of course, you might have an opportunity to talk to her after the pregnancy. Ideally, she would wait at least 2 years before she considers a further pregnancy, and that's because the chance of cancer recurring is usually highest in the 2 years after diagnosis. So you want to avoid her situation where she's getting pregnant too soon again and then has a recurrence. Contraception is very, very important, and certainly for women with breast cancer, we need to think about barrier methods and copper coil. And then, of course, if their treatment has affected their fertility, we need to liaise with fertility specialists to see, do we need to consider embryo or egg freezing. So in summary, care of women with cancer and pregnancy, reach out to your oncology colleagues, your surgeons, your radiologists, close monitoring of fetal growth. We can give chemo, aim for a term delivery where possible, follow up the baby. And if you only remember one thing from this talk, remember this: when you get that phone call from the oncologist telling you that your pregnant woman has a cancer, ask him or her, what investigations would you do if she wasn't pregnant, and what management, and you need a very good reason to change from that. Thank you very much.
Thank you so much, Dr. Fionnuala. It was really a difficult subject, which you tackled so beautifully. Most of us in practice have very little experience of tackling pregnant women who are diagnosed with cancer. And so I think this was really an eye-opener that you can, in many cases, give chemotherapy safely. You just need to know when and how, and you need to balance the pros and cons, and how we should not panic and deliver the child prematurely, because that will create so many more issues. And what I loved was your, the slide about the multidisciplinary approach, how many different specialities are involved and working together to give the best care possible to the woman who's diagnosed with this significant problem of malignancy in pregnancy. So thank you so much for addressing this very difficult problem and for treating women with such care and compassion who suffer from this difficult problem. Thank you so much. Thank you.